Okay, so how does the mechanism of treatment failure impact sequencing? If you know, for instance, that a patient has acquired a mutation or loss of BCMA, then in my mind, you're never going to probably come back to a BCMA-directed therapy until we get good enough to understand which of the hotspots on the BCMA receptor are still sensitive or resistant to the different T-cell engagers that we have. So right now we don't have that data, but there is differential binding based on the mutation, and whether that translates to a better response rate, I don't think we necessarily know yet. If, for instance, it's really dysfunction within the microenvironment or T-cell exhaustion that is a mechanism of resistance, then I would argue that using something with a cell mod, for instance, as a partner would be a way to try and reverse some of that T-cell exhaustion, activate T-cells, and perhaps make them sensitive again to a different either T-cell engager or perhaps collecting T-cells for a second CAR. I don't know, Karina, whether you would agree with that.
Yeah, no, I agree. I think there's so many questions and we don't have answers to that all of us are probably going to do different things and hopefully have bigger data sets to really say what's the right thing for these different patients.
How might the introduction of CAR T cells into earlier lines of therapy impact sequencing? Again, in my mind, if you use a CAR earlier, it may open the door for reusing that target again down the road. So if you use a T-cell engager, for instance, in earlier lines of therapy and progress on continuous pressure with a T-cell engager, the likelihood of that receptor being bindable by the CAR is probably lower. I won't say zero, it's probably lower. So I think the optimal sequence, given a perfect world, would be a CAR T-cell earlier on, followed by a T-cell engager or an antibody-drug conjugate. I think it remains to be seen, given the really great data we saw in the last few weeks on the antibody-drug conjugate plus either bortezomib or pomalidomide, whether that's going to happen. And I think the second set of questions is everybody a CAR T-cell candidate? And I suspect Dr. Patel and I would probably say yes, for the most part, but I think we don't always see all the people that the answer would be no to. And so making sure that we provide adequate access to the right patients does represent a major challenge going forward.
There's one question that may probably apply to both of us. Which step in the CAR T-cell treatment pathway is most key to optimize the treatment?
Oh, you want to go first?
Yeah, it may be different between the diseases.
Yeah.
So I certainly think one of the easiest way to work on it is still the lymphodepletion, because it's really under-researched. And there is a lot of things that we could improve there. Number one, and number two, of course, the quality of the T-cell products and the production times, etc., will make a difference in lymphoma. For instance, if you have these seven-day production times, that will probably change things.
Yeah, you know, it's interesting, and I'm curious what Dr. Patel thinks, but my view would be the bulk of disease going into the CAR is probably one of the most important things we can impact. And so finding the right bridging therapies or that don't impact T-cell collection if you have to start bridging before you can get apheresis done. We know that, for instance, CRS and ICANS are significantly reduced if you go in with less disease burden. So I think disease control is probably a really important one, and then I would agree, how do you optimize LD to maximize perhaps persistence? And I don't think we played with this at all, but if you change the lymphodepletion, can you maximize persistence a little bit better than we do currently?
Yeah, no, I think in the relapsed refractory tumor burden for myeloma patients is the main thing. I think as they're going earlier, especially if they start going frontline, especially for high-risk patients, extramedullary disease patients, do we do a maintenance or a consolidation or a combination? And I think then we have to go into subgroups and see, since we're not curing the majority of our patients with our great response rates, but we don't have that tail, how do we get that tail?
Okay, thank you very much.